Hi, everyone. I'm Elizabeth Hamburg. I'm with the Joe Negro Foundation. And on behalf of the B Foundation, the Brain Aneurysm Foundation, and the Aneurysm and AVM Foundation, and I know we have all of our faces here on the panel, we just want to say thank you. Thank you for being here. Thank you for being a part of our community. We appreciate you taking the time. We're excited to once again come together as four voices for one cause, as you can tell by our forum. So we're really grateful for each of you. And as you know, each of these foundations is really passionate about serving patients and families and also about funding medical research. So we're really excited to hear from Dr. Ashour tonight and hear, where research has been, where research is going. I know one thing that's been exciting for me is I've gotten to update some of the statistics on our site because of the research, and outcomes are getting better. So together we're moving that needle for better outcomes for patients and families living with aneurysm and AVMs. So we're going to hear from each of our foundations a little later in the evening. I know I've said this, but we have some new people joining on. So housekeeping items, we're going to keep everybody muted and without video, just so that we can really listen to our speaker. And then we'll give you the opportunity to ask questions. So we'll hear from Dr. Ashour, and then we're gonna hear from each of the foundations, and then we're gonna open the floor up for questions. And you can either write a question in the chat or raise your hand. And if you would like to ask a question but don't want to be on video or audio, you can just say that in the chat and we'll ask the question for you to Dr. Ashour. Let's see, so we can have one of our moderators answer the questions. So each of these foundations has been able to host on a different topic. We have one coming up that Christine and the Brain Aneurysm Foundation will be hosting coming up next, and you can tell us about that. Actually, Christine, do you want to tell us your topic and just to kind of be out? I think we haven't set a date yet, but that's coming.
I think we targeted December. Am I right about that? Probably early December, I'm thinking, but it's going to be on advocacy. And I think most of the groups have taken part on Advocacy Day in some way. We've been going to the Hill. God, I don't know how many years now, probably at least 8, maybe 10. The last few years have been virtual. And we do have legislation out there. In case you don't know, Dr. Ashour, some of the people just joining, we have a legislation called Ellie's Law. And we've been working on that for probably at least 3 or 4 years. So Ellie's Law was named for a 14-year-old girl who died her second day of high school in North Carolina from a brain aneurysm rupture. So the legislation is asking for $10 million for 5 years, so $50 million in total over what NIH, NINDS is already appropriating for brain aneurysm research. And we also have some appropriation language around early detection and best practices. Always trying to have the federal government make September Brain Aneurysm Awareness Month too. So, there is lots involved. And so I'm happy to say that finally today made the decision that March 23rd, we will be live back on Capitol Hill. So good, bad, or indifferent, that's the format, going live, and hoping a lot of you can join us. It's a great time. We'll have training we'll have training the day before somewhere nearby, and it's just a great day. So once the new year kicks in, we'll get some more information put out there, and that's why this last webinar for the 4 of us coming together will be an advocacy, and we'll talk more about what to expect on that day and actually what legislations and appropriations that are out there now. And we just need the support of everybody, that's for sure, and I think all of us here understand that. So thank you, Elizabeth.
Oh, thank you so much, Christine. So I know when JNF got the topic of research, the first person that was recommended to me was Dr. Ramsey Ashour. So we're really excited that he was able to join us. He actually sits on our medical advisory board. So he helps us decide which research is going to have the most impact, which research to fund. He's an assistant professor in the Department of Neurosurgery at Dell Medical School, a UT Austin alum. He completed his residency at the University of Miami, then fellowships in neurointerventional radiology at Harvard, and in complex cranial surgery at Tampa General Hospital. He's a passionate clinician, researcher, and educator, and he's determined to help redefine the future of medicine in all of these realms. And I know where he's at UT, he sees boundless opportunities to collaborate with investigators in the natural science and engineering colleges, particularly in the realms of device development, translational research, and 3D printed cerebrovascular applications, which sounds really exciting. So he's, let's go ahead and dive in. Dr. Ashour, the floor is all yours.
Thank you so much. I really appreciate the opportunity to share some thoughts on what's on the horizon for brain aneurysms and AVMs. I would like to say I think advocacy is very important, even though we're talking about research today. And not just advocacy, but I think, in my space, we're so focused clinically on, taking care of patients. But I was recently reading this book. I don't know if you've read it, The Emperor of All Maladies. It's like a biography of cancer. It's very well written. And just as important as the clinical campaign is winning the hearts and minds, right? So the political campaign around getting behind, a disease is super important. And I think, getting out the awareness, both, to the public and to, the legislature is really what it takes to get funding and to really move things along. And, for brain aneurysms and brain AVMs, I'm going to try to share my screen. Or I think I need to be given permission to do that. It says I have to be a host. Brain aneurysms and AVMs are, in the grand scheme of things, when people are looking at the world of stroke, not the most common conditions.
You should be able to share your screen now. Sorry about that.
Success. So I was saying that, brain aneurysms and AVMs are not the most common conditions when it comes to the world of stroke, but they are so impactful. They can be very devastating. Lot of resources, energy, effort at many different levels to be able to take care of just one person with an aneurysm or an AVM, ruptured or unruptured. And a lot of the accreditation that goes into what defines a comprehensive stroke center from, in a hospital setting, really what it boils down to is the ability to take care of these complex and challenging conditions. So even though they're not the biggest slice of the pie, we all feel, maybe preaching to the choir, but it's a very important cause. And so I think, the research is one piece, but the politics, the funding, the fundraising, the support groups, all of this matters. And so I appreciated that comment at the beginning about advocacy, because we can't get anything done, in the trenches if we don't have the hearts and minds and if we don't have leadership on board. But anyway, going forward, I have no financial disclosures. Aneurysms and AVMs, as we all know, are very serious, and so there is this feeling that they can be ticking time bombs with potentially devastating consequences. There's a lot of data that has been worked out, and there's a spectrum if you look at the literature, but generally it's held that when an aneurysm ruptures, there's about a 50% chance of dying. And even if you survive a ruptured aneurysm, about 2/3 of survivors will have some form of disability. Similarly with brain AVMs, less common aneurysms, but very devastating condition to have if it ruptures. In particular, 15% chance of dying, 30 to 50% of survivors with disability. Seizures are also very common in patients with brain AVMs. So these are serious conditions, and a lot of the focus is on rupture. But even when if you have an aneurysm or an AVM that has not ruptured, that is something that is hard to get your mind off of. And even though in clinic we see people all the time, and we're often providing some level of reassurance, You know, when you're looking at a picture like this one in a doctor's office and this or in an ER or wherever it is that you come to that diagnosis, that's a watershed moment and a life-changing event, whether it's ruptured or not. That is a part that becomes a part of your book. It's maybe one chapter, maybe several chapters, but it is one of the things that, you know, kind of defines you, and you're in that club. So just to go through a case, and you know, for privacy purposes, I don't have the person behind this case or the cases that I'll show, but you know, I'd like to emphasize to the group that, yeah, we're not just talking about an aneurysm. Yeah, this is a picture of an aneurysm, but behind this there's a person. And so, you know, when we talk clinically, but you know, someone who goes through something like this has parents, maybe they have children, they certainly have friends. So there's a person behind each one of these cases, but this lady came in dying. She had a ruptured aneurysm. There's a big clot, and she was on death's doorstep, dilating a pupil. And so we rushed her back to the operating room and did what needed to be done. We evacuated the blood clot, we clipped the aneurysm, we left the bone off. She actually survived and actually did very well. And you could see that the aneurysm was there on the left, and then it was gone. And then on top of that, she actually had multiple brain aneurysms. So she already kind of had a ruptured aneurysm, but then she had multiple other aneurysms that were untreated. She eventually had surgery to replace the bone on her skull, and then we started her on blood thinners, and then we were able to place a flow diverting stent up on the other side. You can see the clips on the right side of her head, and then the stent being placed on the left side. And then you can see that the unruptured aneurysms were cured after the stent. And so, I mean, we have great technology that's been evolving to be able to fix aneurysms. And so those are great tools in the toolbox to have, and we get to save lives every day. But the research is really important because, as the saying goes, an ounce of prevention is worth a pound of cure. And how do we prevent this from happening? How can we prevent aneurysms or AVMs from rupturing? Can we reverse them? Can we prevent them from happening in the first place? If we find them and they haven't ruptured, which ones should we fix? All of them? Some of them? There are a lot of questions. And I think a lot of the research over the past few decades and ongoing is really just, you know, the basics of understanding why do these conditions occur. More and more, you know, with a genetic emphasis. What are the genes that are involved in patients who have aneurysms or AVMs? What is their biology? Is it inflammation? Is it atherosclerosis? Is it something in the environment? What are the medical risk factors? We know that hypertension and smoking contribute. What about cholesterol? What about other medications or other conditions that relate? Should we screen for them? Certainly we have some sense that in the familial cases where you have two first-degree relatives with aneurysms, that's very clear. But these are scary and potentially devastating conditions. What's the data on that? So these are active areas that have been looked at. And as I mentioned, when should we treat them? We're finding a lot more aneurysms nowadays and AVMs because imaging technology is so readily available. In the past, they would only find them when they ruptured, but nowadays, if you have a headache that is, you know, more than usual, or you have new onset headaches where you previously didn't have an established history of headaches, or if you just took a hit to the head, you're in a car accident, you have a fall, it's very easy to get pictures. And most commonly nowadays in our clinic, when someone has an aneurysm, it's usually discovered accidentally on a scan taken for something else. And so, you know, we're trying to understand what to do and when to intervene in those kinds of cases. So a lot of studies for aneurysms and AVMs are looking at the natural history and trying to understand the risk factors, size, shape, location, previous history of rupture. These are all things that we are looking at that have an impact on the rupture risk. And I cited these couple of studies 1 and 2 decades ago that really kind of changed practice, because the data were surprising when they followed hundreds and thousands of patients with unruptured aneurysms for many years. They actually found the numbers to be quite low in terms of annual rates of rupture. And there was definitely debate and controversy about how these studies were done. And everybody who takes care of patients with brain aneurysms sees small aneurysms rupture. But the data was caused a paradigm shift where the conversation became much more nuanced about when to treat an accidentally discovered small unruptured aneurysm less than 7 millimeters. In the past, it's a much more individualized conversation, but there's still work to be done. And so just to kind of show another case, this person has 2 aneurysms that are very small, with the arrows showing them on his angiogram. They're both, kind of nice, round, smooth, small aneurysms. So this is the kind of case that usually when we're talking to people on that natural history data, we say, well, the aneurysm is small, it's smooth, it's got a nice round dome, it's unruptured. I think a lot of people would not recommend treating these aneurysms in a patient like this. So the kicker in this case is that this person actually did present with a rupture. So this wasn't somebody that I saw in clinic. This is somebody who came into the hospital with a bona fide rupture of which aneurysm? Well, that's another question. When he was admitted into the hospital, the slightly larger aneurysm in the middle was treated, it was coiled, and it was felt to be the source of rupture just based on the symmetry and the pattern of blood. But then there's this other, slightly smaller aneurysm that was not treated. And then, I was called to, give an opinion on, if, when, and how to treat that. And what a challenge, because, the data tells us that these are small aneurysms and they have a very low risk of rupture. Can we really be sure which aneurysm bled? The pattern of blood is one marker, but it's not guaranteed. Sometimes aneurysms can be on one side of the head and the jet stream can shoot to the other side and cause a symmetric pattern of blood. It's not always the biggest aneurysm. So we have some information and some historical data, but it's not perfect. And this is an example of that. One of the things that I think we're very excited about, which is not quite ready for prime time yet, but is more in a research phase, but is coming, is this ability to provide individualized recommendations based on high resolution vessel wall imaging, where we can see contrast enhancement in the vessel wall and try to get information about which aneurysm is the bad actor in a person who maybe has multiple aneurysms and it's not clear which one bled, or in the setting of someone who has an unruptured aneurysm, and we follow a lot of patients with aneurysms. We don't treat every single aneurysm that we find in patients who come to our clinic. Well, is there a way to be able to take a picture and get some meaningful information that tells us that, that aneurysm is risky and it has a high risk of bleeding, we should fix it, whereas this one doesn't. So I think that technology is coming. And that is something that is not really, widespread and readily available now, but I see that as really helping to give, an individualized recommendation, to an individual patient for aneurysms specifically. Genetics are very important. So we already know a lot of things about sporadic versus familial aneurysms, and that's been a lot of the work in the past, and we know, for example, to screen, family members of patients and patients themselves with certain specific genetic disorders that are just known to be highly associated with aneurysms. But going forward, what we're really looking for, in an aneurysm specific situation is to really be able to predict the risk based on a genetic profile where, you can screen someone's genome and then find predictors that say this person is more likely to develop an aneurysm, and then what can we do to prevent that? Or, okay, this person has an aneurysm, and then based on their genetic profile, this genetic mutation is associated with growth of the aneurysm or instability of the aneurysm or a larger size aneurysm or an aneurysm that is more prone to rupture. And kind of one or two steps removed, studying the medical conditions like hypertension and atherosclerosis and other inflammatory disorders that are associated with aneurysms. Well, when we learn about the genetics of those diseases, it helps us learn about the genetics of aneurysms. So I think that there's a lot of emphasis on this, and our hope is that eventually we'll be able to identify therapeutic targets to prevent aneurysms from forming, or if they're established, prevent them from rupturing. And really, prevention is key, because at least as it stands now, the feeling is that once an aneurysm develops, you can't turn the clock back on that. You can't make it go away. You're kind of left with having to deal with managing it, either fixing it, following it. But it would be really nice if we could get ahead of that and prevent them from even forming. So I think that the answer to that lies not in the tools that we have today, but in the research that's happening. And this is very important work. Just a word on AVMs. Similar emphasis over the past 10, 20 years, gathering data for a long time. It was held, and to a large extent to this day, it's held that a brain AVM annual rupture rate is 2 to 4%, but that's a one size fits all number. The reality is it really matters where it's located, what the venous drainage pattern is, the size of the AVM, whether it has a history of prior rupture. So there's ongoing work being done to try to not lump AVMs into just one category, and to try to right size treatment recommendations, because the treatments themselves are high level treatments that have their own risks. There was a bit of a backlash on AVM treatments with a trial, the Aruba trial, which looked at conservative management versus all the different modalities of treatment that we currently have. There's a lot of criticism and controversy of that study, but the reality is it was a paradigm shifting study, and we're similar to the natural history studies of aneurysms, similar pattern. It kind of swung the pendulum away from just treating every single AVM. So really, it's a nuanced conversation, and more work to be done in this arena. In terms of AVM genetics, similar to what I was mentioning with aneurysms, we can learn about the genetics to some extent from established genetic diseases where AVMs are very common, particularly hereditary hemorrhagic telangiectasia. There is a feeling that AVMs are potentially dynamic, even though we sort of routinely counsel that this is probably something you were born with, something congenital. There's a lot of emphasis on looking at the genetic pathways to try to map out whether AVMs can be dynamic. We do see them evolve. There are rare cases where they develop where they weren't previously seen. And so what are the pathways? What's the biology? Is it an inflammatory cascade? Is it angiogenic? So I think and with AVMs, probably more so than aneurysms, really, there's ongoing work and even trials now to be able to actually treat them medically to see them regress. And so these are just a couple of samples, but in animal models, there are signaling pathways that have been identified, and in animal models, AVMs have been reversed with targeted therapy to those signaling pathways. And there's even studies now in humans to give chemotherapy agents that inhibit vascular endothelial growth factor and to see if that will allow for an AVM to regress. And so I think as much as surgeons are very enthusiastic about developing their skills and developing their expertise to be able to carry out high-level surgical resections for AVMs or embolizations or radiosurgical treatments, ultimately what we would love is to be able to not have to do these procedures and figure out a way to either prevent them or make them go away once identified. Beyond just understanding the biology and the natural history, treatments are always improving. There are still limitations in what we can do. I mean, here, this picture is, you can see that there's an aneurysm clip under a coil mass on an aneurysm that recurred after coiling and required clipping. So all of our treatments, we are very thankful to have the tools in the toolbox, and there's an ever-expanding armamentarium that we have, and we can do better. Just as one example, this is an unruptured basilar apex aneurysm indicated by an arrow. This was treated over a decade ago with a sort of a complicated stent construct called a Y stent, where because the aneurysm has a wide neck, the coils would fall out. So it has to be buttressed with stents. The patient has to be on 2 blood thinners, but looked like a good result over a decade ago. And then 9 years, imagine if you had your aneurysm treated and you thought you were in the clear and you had these pictures showing that it looked gone. And then 9 years later, you're looking at a picture like this, where the aneurysm looks bigger than it was when you started. And so then this aneurysm was coiled again. So a catheter was driven through the stents, more coils were placed. A year and a half later, the aneurysm is recurring again. More coils were placed, and you can kind of see on an x-ray that this patient has a very large coil mass. The x-ray doesn't show the brain anatomy, but right behind this coil mass is the brain stem, which is now being pushed by the coils. And so we need to do better. And so there are a lot of different arenas that are actively being looked at on the horizon for being able to improve our ability to operate surgically. So even though endovascular treatment and radiotherapy have really taken off for aneurysms and AVM, surgery is still a bona fide consideration in many cases. So there's improved intraoperative imaging, there's novel techniques, there's minimally invasive techniques where we can do the surgeries through smaller holes. On the endovascular side, there's always new devices being studied, new approaches, robotics, or even hybrid ORs, like one when I was in Boston, we were working on developing one where you can kind of do combined surgery and endovascular procedures in the same suite. So this is very important, and this work is ongoing. I think endovascular techniques for aneurysms and AVMs have been revolutionary. These are still high-level treatments, and I would say that the risk of a procedure is not just the size of the incision. I mean, it's a very high-level thing to take a catheter into the brain and place a device like this inside of an aneurysm, even though it's through a small little pinhole puncture in the wrist or in the groin. It's still a high-level procedure. So, kind of knowing all the different tools in the toolbox, the risks and benefits, and the ins and outs of them is very important for us fixing aneurysms. But there are certain things that, the biology matters. So, for example, there are now flow diverting stents with modifications to their surface that make them safer in terms of not necessarily having the same complications of clotting on the metal with the stent. There are intrasaccular devices like this one where they can be deployed in an aneurysm and potentially obviate the need for the antiplatelet therapy that is required with stents. There are newer liquid embolic agents that allow us to treat AVMs more aggressively with endovascular, so that it's not just an adjunct to surgery, but potentially allows us to be more aggressive and go for the cure and avoid surgery altogether. So these are ongoing efforts. There's been a lot of buzz and enthusiasm about radial approaches. This has taken off already in the cardiology world, going through the wrist to be able to do cardiac procedures. And so now in the neural world, we're looking at this, and there's a growing movement of neurointerventionalists who are, doing their procedures through the wrist. You can kind of see this catheter is coming from the groin, and it's a very sharp angle and a very challenging catheterization to get into this vessel to go to the brain. But coming through the wrist, you would come up the arm, and then it would be a straight shot, and that was actually what was done in this case when the aneurysm was treated. So these procedures need to be studied. Just because something is kind of the new rage, that doesn't mean that we understand all the ins and outs of it. There can be short and long-term consequences that are different in the neuro world as compared to the cardiology world, but there's certainly benefits, decreased complications at the access site. It's a smaller artery. You don't have to be laying flat for 3, 4, even 6 hours after the angiogram. You can just be up right away. The surgeon or the interventionist doesn't have to be sticking you in the groin area. And so, this is definitely an area that is growing enthusiasm, both from the physician standpoint and from patient standpoint. Just to kind of talk about some of the things, to at least to mention, in Austin, we're very interested in figuring out how to be able to quantitate blood flow in the brain, and it kind of speaks to the multidisciplinary effort. We're very excited with the new medical school. As soon as I got to Austin, I was approached by the biomedical engineering department of Dr. Dunn, and they were just very enthusiastic to be able to translate this technology that they have been working on in the lab for several years and bring it to patients. And so I think, for cerebrovascular experts, not all of us are pure. Most of us are not scientists, basic scientists, but we understand what is needed, and we have a very unique insight and view into what patients need. And so these are very rewarding collaborations where you can sit with very smart researchers who've been working on technology for decades, and then you can just have a very unique interaction where they're trying to figure out how it would be helpful, how it would be useful, what needs to happen to make this helpful for people. And so that's something that I felt that I could just jump right in, because that's sort of like the lab that I'm in all the time. So we're doing this work and presenting it at meetings and kind of taking it forward so that we can do surgery safer for patients. And that's really what it's all about. And then, just a word, I think it's really important. I think on the physician side, sometimes we get so focused on, the disease, fixing the AVM, removing, fixing the aneurysm. And then really what it comes down to is staying connected, because even when we feel like we've done the best that we can for a patient and we've done a technically successful operation, it really doesn't end there. And so what a surgeon considers a success based on a picture, is very different than what the implications are for a person who has to live through this, right? I mean, even that lady, the first case that I showed you, where we saved her life and she had a great outcome by all measures based on where she started, but she has disability and she has memory issues. She has cognitive difficulties. We see a lot of patients who've gone through this, and yeah, they had a quote unquote excellent outcome because, the disease is so devastating, but you'll find that, they're divorced, or, they're estranged from their family and friends, and their whole life has been just uprooted in a very significant way. And so I think, the work that is being done by all of the foundations on this call is extremely important. And we're very much interested in collaborating and connecting our patients with the online communities, with the support groups, to be able to make sure that, when we spend all this time and effort trying to get them, across the finish line from the hospital side of things, that they can figure out how to reintegrate and you know, and live and move forward. So I just wanted to kind of put that in there. I think you know, it was mentioned to me that that even Natalie Nierecro is working with Penumbra on their patient focus groups. So that's a great resource as well. And I think the work here is very important. And so I'll just leave it there and say that if anyone has questions, then I'd be happy to take those. But this is very important work, looking towards the future so that we can do better than what we have.
Well, thank you so much, Dr. Ashour. That was phenomenal. You give us a lot of really great information, a lot to be excited about. I'm sure a lot of you have questions, so go ahead and start either raising your hand, putting things in the chat. But before we get to those questions, that was a great segue. I'm so glad that you talked about the need for support groups and what it's like for patients after they have these procedures or after diagnosis. And so I would encourage everyone on this call. I think a lot of you found us through support groups. If you're not part of a support group and would like to be part of one, I would just encourage you to reach out to any of the foundations on this call and join a group and get connected to other individuals that are walking through this. So again, y'all can start either raising your hand, putting things in the chat, and then we'll go through and hear from the foundations. Let's see. So Dina, yes, Christine.
Yeah, I have a quick question for Dr. Ashour. First of all, that was fabulous, and thank you so much. And I love your ability to really see the human side of all of this. And like you said, success as a surgeon seeing a surgery in a picture is very different than the success of that person's life in their family and in their community. So it's really nice to hear you mention that, because that's something that we're all dealing with all the time. But again, thank you for everything. But my question is around AI. Just coming back from the CNS and talking to some of these AI companies for, you know, the 3D imaging for diagnostics and treatment. How do you think that's going to play into treating and following some patients going forward?
Yeah, I think that's a very exciting area. I mean, you know, technology is being developed to really see inside aneurysms now and do volumetric measurements, including pulsatility and indexes of shear stress and flow, basically seeing inside the brain and seeing inside aneurysms in a way that, you know, gives us information. Now, what to do with it, we don't know, but I think the AI piece basically allows us to leverage, you know, major computing power to be able to look at a lot of data, come up with averages, come up with controls, and like understand. I mean, it's going to take a lot of work to sort of correlate that kind of information with what actually happens. But I think it's kind of a bigger extension of the small piece of like vessel wall imaging. But I think it's going to allow us to be able to understand you know, the specifics of individual aneurysms. And then on the genetic side as well, I think that there's just a lot of data that needs to be processed. And so you know, being able to have algorithms, so it's not, you know, an individual, you know, having to kind of, you know specifically what they're looking for, but having an AI platform that can see the patterns, see the trends, see the commonalities, and then, you know, spit it out to us in a way that's meaningful, I think is important in aneurysm, AVM, and is also being done for brain tumors and so many other things that we're involved in. So yeah, I'm very excited about that.
Thank you so much. Dina, do you want to talk a little bit about your foundation real quick, or do you want to ask a question and then we'll dive into and we'll go through everybody and then get into it? We have some great questions coming up as well.
I appreciate that. Thank you. And thank you, Dr. Ashour. This is the stuff that, as you can assume, we get pretty nerdy about. We all enjoy it, and I'm really grateful. Some of the things that you were mentioning, one of which is directly related to my organization, I was really jazzed about, the one with Dr. Cook and everyone, because on the AVM side of things, the idea that you could repurpose cancer drugs and just automatically start curing AVMs is just, well, it's mind-blowing. It just really is something that got me very excited a couple of years ago. I would share that I think you're not going to be surprised that all of us agree that novel research is going to make the difference in the lives of our patients. And truthfully, I think that from our perspective, what we want to do is we want to be able to encourage younger researchers as well. I think that it can be very challenging once you get past a certain point in your career to, as you said, get back into a community of people and really feel how they're doing, right? That you got them past the finish line, as you said. And it was interesting when you used that word, I was like, oh, that's just the starting line. But for you, we want you to 1,000% be concentrated on getting them to that point, right? And then we all want to take over and help out. So I don't have a lot more, honestly, Elizabeth, to say other than we are extremely grateful. We want very much all of us to be doing this novel work in a space. And I'm just grateful that we can do it all together in a way that allows a lot of researchers actually to benefit on an annual basis. And that really is the benefit of the amazing community of people that we serve, giving back to make sure that this happens. So I'm grateful to them as well.
Awesome. Thanks, Dina. And what about the B Foundation? I know you're here. I know Erin is a little under the weather. I don't know if Erin or Laura want to hop on and say anything.
Yeah,
let you say something.
I'm here. Thank you. Hi, everybody. Sorry. This is Erin Kressel from the B Foundation. I have COVID this week, but feeling okay. So glad I was able to join. So it won't take too long because I do see there's some really great questions out there, but I did just want to thank Elizabeth for putting this together and Dr. Ashour, obviously, for your wonderful talk, and call out that I loved the examples that you provided. And I think it was really clear, especially when you were able to show us the 10-year gaps between that one patient. I think that just really brought to light the complications that you all have to address. And I think what a few months back when I was talking with Elizabeth about this talk, I think what you really spectacularly brought out was the progression of both preventative and treatment research that has been done over the past 10 to 15 years. And the fact that we're getting into that personalized medicine is really exciting. So I'll stop there, but just want to say thank you, and thank you all for joining. And I'm really excited to hear some of the questions of the group.
Much, Erin. And Christine, I know you got to talk a little bit earlier. Is there anything else you want to add?
No, I mean, I just loved everything Dr. Ashour had to say, and it's just important, like you said, the education, awareness, advocacy, it all comes together, you know, and includes the research. So it's good we're all doing what we're doing, and it's just nice to hear someone in the medical community, you know, echo our sentiments and really understand what we're trying to do. So just thank you again.
Awesome. I couldn't agree more. Okay, we have an attendee. Let's see. We have Zoom user. I know you've had your hand up for a while. I'm gonna allow you to ask a question.
Yeah. Hello. I don't know why my camera's not working, and I don't know why I'm coming up as a Zoom user, but thank you so much for putting this panel together. My name's Jamie Meltzer. Today is actually 9 months since my sister, 43 years old, tragically passed away from a ruptured aneurysm. So the B Foundation has been extremely near and dear to my heart, and I will continue to do everything I can to advocate, to find out prevention. So Dr. Ramsey Ashour, I would like this question to be for you. When you talk about genetics, you know, this is the big question now in our household. Obviously, we didn't think we had any gene associated with this. My father had polycystic kidney disease. His entire side of the family did as well. My sister and I both were checked for cysts. We did not have them. And we were told well, you don't have cysts, so you don't have polycystic kidney disease. Do you feel that that is the case, or do you think that we should, if I should be getting genetically tested, obviously it's too late for my sister. You know, I'm trying to find some type of familial association with being 43, no signs, no symptoms, and a 23 millimeter giant aneurysm rupture. Is that a long-winded question? So, nobody seems to be giving me an answer as to whether or not this could be genetically related to polycystic kidney disease, even though we're not showing, she wasn't, and I'm not showing any signs of cysts.
You know, I think, you know, there's having the, I mean, I'm not an expert on the genetics, but what I would say is, I think, you know, there is having the mutation, and then there's having, you know, sort of the phenotype or the penetrance, like how that is actually expressed in individuals. You know, sometimes there's a disconnect. Sometimes you can have the mutation and then it expresses itself 100% of the time. But sometimes you can have a genetic mutation that doesn't always show itself in its full form with all the classic manifestations of a disease. So I couldn't tell you from the standpoint of a geneticist or a kidney specialist who deals and eats, breathes, and sleeps, you know, polycystic kidney disease all the time. Like, if they have a sense that, like, that's the relationship, that you have to have cysts to have this disease, I don't know that. But what I do know is that, you know, if your father had an autosomal dominant polycystic kidney disease, and it sounded like it ran in the family, you know, pretty significantly, it's possible that, you know, that has such a strong association with the development aneurysms that, you know, it may be a question that we don't fully understand.
Right.
But did your father also have an aneurysm, or it was just that your
no aneurysm, and was checked for aneurysms, no aneurysms, had a kidney transplant a few years ago. I obviously went a week following my sister and had the MRA, and I thankfully right now do not have any aneurysms, but I constantly have the association in the back of my mind, because it's ironically, my father's whole family has polycystic kidney disease, and here my sister, 43, out of the blue one morning has a ruptured aneurysm. So just,
you know, I think, you know, aneurysms are, I mean, depending on who you ask, I mean, they're not uncommon. I mean, they probably happen in 3 to 5% of the population. But what I don't know is, you know, so you have to kind of, you know, weigh the probability of that it just was just a sporadic event versus, okay, in a family with, you know, with this obvious history of polycystic kidney disease, if you had the mutation, but its penetrance, meaning, you know, its expression, you know, in terms of its physical signs and symptoms, and for example, like aneurysms, if that's not a 100% penetrance kind of situation, then there's a certain percentage that, yes, it could be that you have a genetic mutation that predisposes you, but you just don't have cysts on your kidneys. So, you know, I don't know. I mean, it might be something to pursue, but I'm not an expert to give the recommendation. I think it's kind of one of those things where it's like, the thing with screening is that, what do you do with that information? Sometimes it ends up raising more questions than answers, and you have to be careful with it. But you know, I think it's a valid question.
Well, I thank you all for the work that you're doing, everybody on this panel, because I never thought I'd be part of this. I never wanted to be part of this, and I just thank you all for what you do, and I just want to find something that helps prevent in the future.
Thank you so much for your question. We're very sorry for your loss. And I hope that that answer was helpful. Here, I'm going to ask a few more questions. We have another one here on the chat. Chris says, hi, as a spinal AVM survivor, I'm curious if there is research on areas outside the brain.
Well, in terms of spinal AVMs, spinal AVMs are quite rare. specialize in this, we may only treat and evaluate a handful of patients, per year, like maybe 3 to 5 patients. There are certainly articles published on spinal AVMs, and sometimes they are more, because they are so rare, with the evolving technology to be able to submit videos of surgical procedures or intraoperative imaging, or to collect a case series over several years with outcomes and some of the technical aspects. But I don't know of a ton of research being done at many places. I mean, I think the institution with the biggest experience would be the NIH, and the NIH actually has a great process to be able to follow people with rare conditions all over the country. I mean, probably all over the world, where they will proactively have the people come for follow-ups and for imaging and for treatment, and follow them for many years. And that was certainly the case in spinal AVMs. And a lot of what we know about the classifications of spinal AVMs, the natural history, and the management options came out of seminal and important work that was done at the NIH over many years. But I would say that it's not, because people try to keep things separate, and they're just exceedingly rare in relation to brain AVMs. I think that probably what will happen is that the brain AVM research is going to sort of, people are going to make analogies and assumptions from more of that work that's being done and kind of apply it to spinal AVMs. But they are a distinct entity with very different considerations, certainly in terms of treatment and in terms of how they behave. So it's just a pretty rare disease.
Thank you, Dr. Ashour. Here, I'll do one more from this list. And I know, let's see, I think Dina has a question as well. Here, I'll do one more from this list, and then we have someone raising their hand too. Is the future imaging done more like the kind where an angiogram is done based with radiation, or more like MRI where radiation is not used in imaging?
Well, for what I was showing in the talk, the high resolution vessel wall imaging and wall contrast enhancement, that's more MRI technology. But I would say that that there is in the world of angiography, there's like robotic angiography. There's cameras being put on the tips of microcatheters that are looking inside aneurysms and trying to gather information about what flow is happening inside an aneurysm, what the pathology is on the vessel wall side, even being able to look at stents that have endothelialized after treatment. So people are working on technology in the world of cerebral angiography as well, in terms of being able to steer catheters remotely, not just manually, but robotically, and also putting either ultrasound technology or video technology to be able to advance that work forward. But what I was talking about in the talk specifically is MR based, without the ionizing radiation.
Sounds good. Thank you, Raylene, for that question. Dina, did you want to ask? I know you had a great question.
I did. So I was curious if you've seen any new information regarding inflammatory diseases like psoriasis, for example, playing more of a factor in aneurysm formation.
I mean, I think, what I'm familiar with mostly is the collagen vascular diseases, things like, Marfan's or Ehlers-Danlos. Those are very strong associations. Psoriasis or even like rheumatoid or autoimmune kind of things like that, I don't think it's a very clear connection that I know of personally.
Okay, and we had another question. Why was the brain aneurysm that was initially coiled, then 9 years later was found to have grown coiled again and not clipped?
That's a good question. Well, that patient, so she had this complicated Y stent construct. So it's two stents that converge, and then in the basilar artery, which is one of the most important arteries in the brain, feeds the brainstem right in front of the brainstem. So there's a lot of metal there when you have two stents in that artery. So as a result of that sort of mandated that she be on antiplatelet therapy, and she's on dual antiplatelets because of that stent construct that she has. So I think one factor would be that if she were to undergo craniotomy for surgery, she would have to stop the blood thinners, and there would be at least some theoretical risk that the stents would thrombose. Now, 10 years later, maybe that risk is not sky high, because hopefully those stents will have endothelialized, and it's not like the metal is exposed, to the blood vessel lumen. But still, there's a chance, and the consequences of stent thrombosis would be potentially catastrophic. So that's one issue. And then from a technical standpoint, clipping an aneurysm when there are stents in the parent vessel and when there's a large coil mass which is coming down to the neck can be quite a challenge, because the coils and the stents interfere with the clipping. And then all of that, on top of the fact that the basilar apex location is very deep-seated and is, just generally speaking, even aside from the stents and the coils, probably the most, challenging and complex, aneurysm surgery that exists. In fact, one of the big driving forces for all of the endovascular treatments that we have was driven by, finding a solution for basilar apex aneurysms. That was where, a lot of this first started in terms of aneurysm coiling, because the surgical outcomes historically were so poor in that location. But, in that particular lady, I don't know. I mean, I don't know what's going to happen if the aneurysm grows back and the coils start to push on the brainstem and she becomes more symptomatic from that. Then yeah, I think that's going to have to be considered.
Certainly a lot to consider. Thank you so much, and thanks for that question, Stephanie. And Dr. Ashour, I know we're right at 7 o'clock. Do you have time to answer maybe maybe we can do 2 or 3 more questions? You do? Okay, awesome. Thank you so much for your time, and then we'll get everybody wrapped up. Let's see, we have Carrie Rice. Let's see. Or say hello. Hi, Carrie.
Yes. Hi, everybody. Thank you so much for taking the time to do this. I totally agree with Jamie, who called in first, about how this isn't really even on your radar until it becomes your whole world. In 2016, I had a sister who survived a rupture, and it was at that time thought of really as kind of like a one-off. And then 10 weeks ago, another sister had a rupture, and it's still, just left rehab last week. And so there's 9 siblings in the family. So we've all had our MRA screenings, which discovered 2 more unruptured siblings, and 2 brothers. So I guess my question is related to the genetic piece, as kind of like Jamie mentioned, where it's not so much the location in the brain, I guess, because that doesn't really matter. It's just maybe the weak walls, and what kind of more information could we seek out as a family to try and figure out what the connection might be, as all of our children kind of get towards that age of adulthood. There's 22 grandkids on the family as well. So that second generation of children as well, if you have any insight on that.
It's not really clear to me. I mean, I think it's very clear that when you have a family history of aneurysm, we know that the risk of having, the aneurysm in subsequent family members, goes up by an order, by at least 10 times the risk in the general population. And also there's a feeling that those aneurysms have a slightly higher propensity to bleed, or if they do bleed, the consequences, the outcomes tend to be worse. So I think definitely having a strong family history lowers the threshold to consider treatment, and also brings about the recommendation for screening. But like, to sort of take that, into a bigger picture and say, does that put you at risk for other aneurysms? Like, sometimes I'll see patients who, they'll say that, oh, you ask them, do you have a family history of aneurysms? And they'll tell me that, well, these family members had abdominal aortic aneurysms. And then, like, how does that get factored in? Like, is there a propensity? Is there something in my genetics that makes me more prone to forming aneurysms? Probably yes, but the brain is just, a susceptible area based on its biology, because the brain's blood vessels don't have the reinforcing walls and supporting soft tissue structures that blood vessels in the periphery have. So I think that, I think certainly, there's a genetic component, but will it actually be expressed in the formation of aneurysms at other sites outside of the brain? I don't think that we're ready for prime time to say that if you have that kind of a strong family history, for example, that every family member should go and be screened for abdominal aortic aneurysms. It's not worked out. But I think, I think the brain aneurysm screening and having a lower threshold to consider treatment is solid.
Thank you. Did that answer your question, Carrie? Thank you. Okay, we have, let's see, we have, I think, one more, and I think hopefully we'll have gotten to everybody. Let's see, it sounds like the research treatment describes are before rupture. Is there a focus on post-rupture and saving blood vessels and restoring function?
Well, yeah, I mean, there's a lot of focus on outcomes after aneurysm rupture. I mean, and some of it is getting to what I was saying, is that, I mean, a lot of times we're patting ourselves on the back thinking that, hey, we saved a life and that's the end of the story. But so I think I've seen a lot of research on, delayed, kind of, neurocognitive outcomes, outcomes that are more than just, can the person walk and talk, right? So there's a lot of interest in what is the recovery, what are long-term outcomes after rupture. I guess if your question is more kind of like, okay, in the population of people who've had ruptured aneurysms, like, what can we do to make their blood vessels healthy, or what can we do to prevent them from developing new aneurysms or things like that? I mean, there are definitely, there's a whole world of research that has been looked at and is also ongoing about neuroprotection. I mean, neuroprotection is kind of like, brain protection, but I guess I would say that, for aneurysms and specifically looking at things that reduce inflammation or reduce plaque formation and anti-cholesterol medicines, like medications that can be given, that try to reduce blood vessel wall inflammation, with the idea that that's a contributing factor to aneurysm formation and development. I think that is ongoing, and I think that would certainly, include, patients who had ruptured aneurysms as well as patients who had unruptured aneurysms. I don't know if, and in terms of restoring function, I think, in the world of stroke generally, which I think, subarachnoid hemorrhage and aneurysm ruptures would fall into that. I mean, I think I would probably lump it in with that. But I don't know about, saving blood vessels specifically.
Well, thank you, Dr. Ashour. We appreciate that, and thank you so much for being on here tonight. We are grateful for your time. You covered a lot of great information. I know I learned a lot, and I'm confident that a lot of others did as well. And like I said, we're recording this, we'll email it out so everyone can join us or take a look later if there's anything you want to go back and look at or listen to rather. And I just want to say thank you for the other foundations. Thank you so much, Dina, the Aneurysm and AVM Foundation. Thank you, Christine, with the Brain Aneurysm Foundation. And thanks so much, Laura and Aaron with the B Foundation. We're grateful for all the work y'all do. Also, hi to Natalie Necro, who is here and is our founder. We're really grateful for you. And I just wanted to again say thanks for everyone. If you are on here, we hope that you'll join us again in December. Be looking for our talk on advocacy. We'll be sending that out via social media. And yes, if you are not part of a support group, check out these foundations, join one, be involved, advocate, help us raise awareness. And again, thank you to Dr. Ashour.
Thank you very much.
Thanks,
Dr.
everybody.
Thank you.
Ashour. Thanks, Elizabeth.
Thank
Good
you.
night.
So much.
And thanks, Elizabeth.